Now we're going to move into preschool-age children. These kids are a lot more rambunctious normally. They're able to communicate at a much higher level, although they still don't quite have the vocabulary that we might wish that they would have. They understand directions very well. They can actually perform most of the commands that you're going to ask them for, and they can be a little bit more specific in what hurts or describing their needs or their desires. They can identify where pain is very specifically. The risk of the foreign body obstructions is still really high because while they're not necessarily exploring, they just haven't developed the idea that small objects in their mouth can get accidentally half swallowed or inhaled and cause this obstruction. Now, when we have a child of this age, this is when you can take advantage of the fact that they're very curious to strangers. They've kind of come away from the shyness unless they're not very well socialized with outside people. And you should really be able to kind of get them to buy into the fact that you need to do an assessment. And if you make a game of it, they're often very willing to kind of play along, so long as you let them kind of dictate and control the way that this actually happens. So make sure that you're respecting the child's kind of privacy and their modesty, because they are starting to develop the little bit of shyness about their body. They've had several years now where we've got them covered up in clothing, and they actually understand that their naked skin is something that's not normal. So as we're trying to expose that child, they may become full of anxiety at that point. Now, at no point in time, if you have a child who's just willfully being nasty, should we kind of allow that to happen because we just really want the child to kind of buckle to our will, so to speak. This is where we kind of have to set a boundary. We can go so far, and then at a certain point, like, we have to have the parents kind of engage the child and get them to behave appropriately. Now, when we're talking about children that are anywhere from 6 to 12, the vocabulary has come up enough that for all intents and purposes, these children should be able to communicate with you at a pretty exceptional rate. They may not have a very in-depth or higher level of vocabulary, but they can absolutely describe concepts with you and can engage with the questions that you have. So if you're asking them specific questions, at a 12-year-old, you can ask them pain scales from 0 to 12, whereas a 4-year-old might have kind of the FACES scale, trying to help us assess where this child dictates that their pain levels may be. In the case of the adolescent, this is children that are 12 to 18 years of age. This is, for the most part, becoming a small adult. This is right when we're going to get into puberty, and like determining age can get a little bit more difficult at this point, because we may have some that are not showing quite the signs of puberty yet, or having developed the appearance of being an adult in stature or reproductive age cues. So this can be a little bit more difficult because now we have such an advanced concept emotionally and mentally as compared to, say, your 6-year-old. The child will now become very inhibited at this point in talking about things that may seem to be a little bit inappropriate to them or embarrassing. So this can actually start to swing the opposite way as far as their involvement and willingness to let them or let the EMT kind of get in depth as far as an assessment. And so this will become a little bit more of a negotiation yet again, or just trying to gain that person's trust. So as we were talking about with respecting privacy and the modesty of a teenage child, remember, again, these children are very aware of what their changes are and what's happening, and they've started to develop boundaries, especially about things that are sensitive to them. So they may feel embarrassed about things, but what we really want to do is perhaps try to find out if we can gain that particular patient's trust, and then try to actually kind of get the caregiver to kind of stay a little farther back in this, right? We're not trying to separate them necessarily, but we want to give them the privacy that they may not want their adult caregiver or parent or relative to know about them. So if it's sensitive, try to do this like very discreetly. And again, by you being discreet, you're actually showing them that they can trust you with information. All right, so again, as we were talking about, as a child grows, their proportions change pretty rapidly all the way up until puberty, and then as they go through puberty and they become more adult structured, we're going to see that those changes start to kind of slow down. So in regards to the airway is a significant problem in small children all the way up until probably around puberty, and that's because that they're smaller in diameter and shorter in length. And again, when we have inflammation and other things of that nature in a smaller lumen, a small reduction, right, just a little bit of swelling actually takes quite a bit of surface area, or I should say the diameter of that lumen, away from the respiratory tract. The tongue is a lot larger in proportion to the head. That's because as a child that's say 2 years old, their skull is fairly close to full size, and it's just the face that kind of grows in. Now the musculature of the tongue and things like that are a little oversized, again, in relationship to appropriate kind of sizing. This actually comes back to the epiglottis. The epiglottis is a little bit larger in proportion than to an adult when you're comparing it to the rest of the airway. The larynx is a little bit higher and a little more anterior in a child, and the trachea, again, is smaller in diameter. And I have to stress upon you guys, the smaller diameter lumen of the airway is where we get into most of our trouble with pediatrics. We really just can't afford to lose any of that area. Okay, in regards to infants, infants using their diaphragm, which makes them a belly breather instead of their chest muscles, and that's because the intercostal muscles are really pretty small, and the child has a difficult time actually kind of stressing that small amount of muscle group, and so you'll see that they are traditionally kind of belly breathers at that point, and that's why we kind of get the a good look at the sternal retractions, and then whether or not we have seesaw respirations on real small children, because we're looking to see just how dependent they are on the diaphragm. Now, if we have pressure on the abdomen, we can actually create some kind of intra-abdominal pressure that pushes up against the diaphragm, and this can cause some pretty significant respiratory compromise. So now we're talking about some internal differences that, again, are kind of differentiated in between the child or infant tissue versus an adult, and that's where the lungs are a little more fragile. The ribs are a little bit more springy, right? We're going to say they're cartilaginous. And which really just means that you can probably get a little bit more of an injury to the rib cage without fracturing a rib on smaller children. So that being said, if we sustain some kind of compression injury to the chest, we may not actually see this incredible damage, but there can be some injured vital intrathoracic organs, right? We can easily kind of bruise some of the lung tissue or something like that, or have some kind of tear to some of the vasculature in or around the thoracic cavity without seeing that external kind of fractured rib cage or sternum area. And so again, this is one of those things where we're really looking at what the appearance looks like, because we may not see the things that we would normally see in an adult. We've already talked that the respiratory muscles, those intercostal muscles, are really kind of immature, and they don't necessarily have the ability to kind of work in long stretches of time, so they're going to fatigue a little bit more, and this is where children will start kind of reverting back to belly breathing pretty quickly. And then because their lung capacity is smaller, they actually have a smaller residual capacity, which means that their oxygen reserve is quite a bit less than in an adult. And it's, if you guys remember my respiratory lecture, the average adult male has about 6 liters worth of lung volume, and we're really typically only moving about 600 milliliters of gas in and out in a typical breath, while just normal kind of regular breathing. So if you think about all of the extra tissue that is actually still has oxygen in it, and it's still doing its thing, in a child, they may have 2 liters, 2.5 liters, and they're breathing much smaller amounts of volume, and so they really don't have those reserves that are needed in case of like some kind of shock. So you don't have to necessarily commit these to memory. I mean, for testing purposes, this may help you a little bit, But if you're looking at this, you can kind of see about when we're making that shift into an adult respiratory pattern. And it's right around puberty, because it's right around when we're actually coming up to the adult size. So a neonate is anywhere from 30 to 60. The infant is 30 to, we'll just say 50, just to make things a little more simple. And as you can see, we're getting down into the 20s as they get a little bit older. And it really doesn't shift a lot until we get down to that kind of like 6 to 12, and then we're getting underneath the 20 respirations per minute. So again, look at this, and it's not necessarily about the rate, it's about the effort and the work that they're having to put into this. And so this is where that pediatric assessment triangle is going to kind of reign true yet again. Now this slide is just kind of touching on a couple of things that we've already talked about. So if we've got significant pressure up against the diaphragm, we can end up with hypoventilation, because we're actually creating a little pressure up against the diaphragm. They can't actually get that big deep breath that they wanted to get, which will increase the risk of regurgitation and then ultimately aspirating. Now, this says to keep nares clear in infants younger than 6 months. And one of the tricks that I learned working in the hospital system was to use a MAD device with a little bit of normal saline, and you can kind of use the MAD device to help thin the mucus in the nares if they have a significant mucus problem, which you would think, well, I'm not sure that I would really want to do that, but spraying that small volume of water, the infant will actually kind of let it go into the mouth and they'll swallow it. It's not really going to cause you any kind of inhalation injury. We want to make sure that the child doesn't hyperextend the neck, and anytime that we have secretions where we have some kind of again, mucus problems, or we have inflammation, we want to make sure that we're suctioning as appropriate, but we don't want to over suction, because children really don't respond very well to a copious amount of suctioning. We're going to just hit the nail on the head again, right? And this is the children are highly susceptible to hypoxia because they have less oxygen reserves. They have an increased oxygen demand, and they easily fatigue. So in this says to use a larger bag to ventilate a pediatric patient, and that means that the neonate BVM is probably not appropriate. And in reality, you can probably get away with a pediatric BVM on all peds all the way up into adults, because of the actual volume being delivered. But you know, that's something that you're going to have to dictate with your service that you're working for, your medical control board. And as always, we're just giving them enough pressure with the BVM all the way through adults. It doesn't matter if it's neonate or a full-blown adult. It's just gentle chest rise. We're giving them the breath of life, not the hurricane of death. Now this is a pulse chart for your typical pediatric patient. You can see, again, once we get into that age range where we're in puberty, this is where we're getting back into that normalcy for appropriate vital signs. And you can see that the adolescent is at that 60 to 100 beats, right? That normal sinus rhythm. And as they get younger progressively, that rate gets up. And again, right around the toddler age, we're looking for children to have a pulse somewhere around 100 to just a little over 100. And toddlers that are sick and crying will often see heart rates all the way up into the 180s. That shouldn't actually put you in a very nervous state, right? So these are general pulse guidelines that are not showing you any kind of sickness or emotional distress. So this slide exists because this is one of those things that we were talking about earlier, and when we say that children often compensate really well all the way up until the point that they're no longer compensating, and then they crash on us. And that's because they are very able to breathe rapidly, but they have a larger circulating blood volume in comparison to an adult. Again, this is all about appropriate ratios, right? We're looking at aspect ratios and ratios for certain things, where the epiglottis is larger in ratio to an adult. The circulating blood volume is also larger in ratio than an adult. So this slide is very much hitting it right where it needs to be, and that's the injured child can maintain their blood pressure for longer periods even though they're in shock, and that's because they're able to actually keep tissue oxygenated and keep us kind of in suspense as to where they're at in the shock algorithm. Now, if you guys all remember, we've talked about this kind of ad nauseum as well. Pediatric patients that go into some kind of cardiac arrest type situation are usually secondary to some sort of hypoxia or respiratory event. Hypotension is usually the biggest indicator that you're about to go into cardiopulmonary arrest. If we see bradycardia, you can almost bet that there's something respiratory going on there, unless they have some kind of congenital cardiac problem. BVMing that child is usually the first thing that you want to try before we get into anything else, right? We're not trying to give them any kind of fluid or anything like that right out of the gate. We want to BVM them up and try to get their O2 stats back up and get them breathing at a normal rate to see if we can get their heart rate back up. If you see a child that is significantly vasoconstricted, and this is where they're shunting to the core, they're going to have very weak peripheral pulses. They're going to have delayed cap refill, right? Cap refill can tell you a lot about the end tissue perfusion. And then if they're pale and cool or mottled, these are all telltale signs that we're in that kind of shunting phase where we're just basically trying to keep the core organs perfused. And yet again, the head is proportionally larger in comparison to an adult, and during infancy, the anterior and posterior fontanelles, or what we would call soft spots in the skull, are still open. And this often takes somewhere in the neighborhood of a year to 2 years till they're completely closed. And then the infant may experience excessive heat loss because of the larger size of the head. And this is where, if you're talking about neonates and infants, this is where we really want to kind of keep them swaddled up, and we want to make sure that we're not allowing them to become hypothermic because of their inability to maintain body temperature. Okay, so no doubt while you were in lab, you've already kind of been made aware that when we want to put a child into a neutral position when they're toddlers or infants, again, their skull is approximately the size of an adult skull, with the face being the smaller, less formed portion of the actual head. Because of that, they are not going to be in a neutral position with just a simple head tilt chin lift. And this is where we want to raise the shoulders up to try to get their shoulders and their chest in line with the head. And so this is where you're going to pad the shoulders on any of these small children to get them in that neutral position, and then performing your head tilt chin lift. And then if we're dealing with anybody that's a little bit older than that, let's say 3, 4, 5 years of age, now we're kind of coming into that appropriate size or ratio. And this is where we're putting a little elevation behind the head for a small child, not an infant or a toddler, all the way up through adulthood. Now, in regards to those soft spots or the fontanelles that we were talking about, if you see bulging, that's going to suggest some kind of increased intracranial pressure. And then if they're sunken, this is telling you some telltale signs about dehydration. Okay, so when we're talking about internal organs and the child patient, we have to remember that the musculature around the abdomen is immature, and it's offering less protection to those organs. And so we may actually suffer some kind of internal organ injury that we would not normally suspect in an adult patient, but just try to be aware of the fact that we just don't have that nice, thick, healthy girdle that's surrounding the organs and keeping them pretty much in the place that they're supposed to be. And so just make sure that that's an index of suspicion for you in any kind of significant trauma event.